So again, my name is Pat Smith. I'm president of the Lyme Disease Association, and I want to thank you all for coming today. About the Lyme Disease Association, we are a national nonprofit. We've been in existence for 21 years. We raise research for prevention, education, dollars for prevention, education, research, and patient support. And what's significant is we're all volunteer organization with no employees. 96% of our revenues that we collect go directly to our programs. With our partners in Connecticut, we helped establish the Columbia Lyme and Tick-Borne Diseases Research Center. We've been part of the combined federal campaign for 2012 and for the past 7 years. We are partners with the Environmental Protection Agency, a GuideStar member. We have 41 other organizations that we have a relationship with, that we work with across the country. Last year, I testified before the U.S. House of Representatives Global Health and Human Rights Subcommittee. And so that's a little bit about us. Now, the kind of research we fund, we like to think that we fund high-quality research that goes on to be published. And to date, we have had publications of research we funded in 29 medical journals. We think that's a pretty good statistics. And we have funded institutions across the country for the projects that they have. And I just thought it would be interesting to look at the first study that we funded that was published, because this is often cited, was actually early work on PCRs, showing that antibiotic treated patients who were treated over an extended period of time, 72, which was 74%, were found positive PCR, and the rest had negative PCR. And these 62 healthy volunteers were PCR negative. So I think that's one of the significant works that is often used to show that that's something happening and DNA is continuing to exist in patients even after treatment. The most recent publication we've had is in Northeastern Naturalist, and that was this year. And actually, it's in Vermont, a researcher in Vermont, and doing work on finding out what the ticks are there, the percentage of deer ticks carrying the bacteria, which was 9%. And what I found to be interesting, didn't know it at the time, but that basically the latitude of the study, the northern latitude of the study in Vermont, is pretty much the same as the northern latitude of where we are MMWR here today in Minneapolis and St. Paul, and I'm sure that Ellen Stormdahl is going to talk about ticks and infections in this area. We have a number of other studies on genomes, on biofilms, and on the neurologic manifestations of Lyme disease. And one I just want to mention, because a lot of times I hear from patients and physicians that they see, especially children, that appear to have symptoms in the GI tract related to Lyme disease or other tick-borne diseases. And this was a study showing indeed that using PCR, that this physician was able to demonstrate that there indeed was a DNA in the gastrointestinal tract. That's just the Columbia opening back in 2007. This is our 14th annual meeting, our first in the Midwest. We were very happy to come here because we know the numbers of cases here have become staggering. So we're happy to be here today. And I wanted to just tell you briefly that our welcome wagon, if you will, and actually I was going to hold it up, but I left it outside, was that we came, oh, there it is, in the back of the room. Ruth Waddington from LDA is holding up a bag. Inside that bag was a tick that she found crawling on her in the hotel here in Roseville. I don't know what that says, but I just thought it was some kind of omen that tick was there. These are some of the materials that the LDA produces and provides, and this is a education video that's available online. Anybody can use it in the classroom or whatever directly. We also have Lyme Aid for Kids program. We've given out over $230,000 for children whose families have no insurance. We've done quite a number of things for Lyme awareness. In DC, I mentioned the hearing last year. That was very significant. Global Health and Human Rights Committee in Washington, DC, and it was on the impact of Lyme disease worldwide. And we had a number of researchers testify, and I talked about the problems associated with patients and physicians with Lyme disease. There are several pieces of federal legislation currently pending in Washington. And just briefly, I'm going to touch upon the total reported cases of Lyme from 1990 through 2011. Now, these are CDC figures, but we did the mapping and the compilation. Basically, what that means over that time period, 429,851 cases were reported to CDC nationwide. However, the CDC indicates that that's only about 10% of actual cases. So if you look at it that way, we're talking over 4 million cases of Lyme disease over that period of time. This is a graph that we've done, and these things, by the way, are available on our website for you to print out. We also have some copies of the current map out on our table. And this basically shows you the top 10 states graphed out as their percentage of Lyme. And also you'll see that Wisconsin was number 4 and Minnesota was number 7 in the country in 2011 in Lyme disease cases. This is the incidence. Incidence means how many cases per 100,000. And again, we did the top 15 states with this, and you'll see that Wisconsin and Minnesota are also in that factor. And again, you can find that information on our website. By age group from 1990 through 2006, and it still continues along that line, you'll see that unfortunately 5 to 9 and 10 to 14 are the highest age groups generally that are affected. Now this is by age and sex, and you'll see that the lower age groups, the males are particularly more at risk for Lyme disease. And unfortunately, the born and the unborn, as I say, are affected by Lyme. And I thank Dr. Alan McDonald for this. This was a spirochete from a fetal brain showing that Lyme disease was there. And in 2009, the CDC said that Lyme had a higher incidence than HIV. We thought that that was extremely significant. Also, you often hear that there are no deaths due to Lyme disease, yet this is from the CDC over a period of 2002 to 2007, showing Rocky Mountain spotted fever and Lyme cases, and they consider Rocky Mountain spotted fever to be extremely serious disease, and you will see that the number of deaths reported over that time by CDC itself were the same number. Okay, these are some maps showing you, in case you live in the area like you don't already know, but showing you how much Lyme disease is Minnesota and Wisconsin. These are from the health departments there. Obviously, the darker the colors there, the more Lyme is prevalent in that region. And I just thought this was really interesting, and this comes from the Companion Animal and Parasite Council. We happen to work sometimes with IDEXX Labs. They have given us some training about Lyme in animals, and I thought these numbers were quite astonishing. And out of this study, for Wisconsin, they tested 53,904 dogs. The positives were 5,400 positives. That was 10%. And 6% of the dogs of the nation that were tested were in Wisconsin. Minnesota, they tested 41,054, and 3,707 were positive. That was 9.02%, and 4% overall nationwide of the dogs were from Minnesota. This is just in closing. This is a billboard we had on Times Square last year, electronic billboard, which we were trying to raise awareness about Lyme disease. And so on that note, I am very pleased to introduce our morning session facilitator, Bill Stitch from the University of Missouri. He's our conference co-chair, along with Dr. Brian Fallon from Columbia, whom you'll meet later. Bill is professor of parasitology from the University of Missouri Department of Veterinary Pathobiology. He's a counselor for the Society for Tropical Veterinary Medicine. He's on the board of directors member for the Companion Animal Parasite Council. That's actually the slide I just showed you. He's on the editorial advisory board of the journal Veterinary Parasitology and editor-in-chief of Animal Health Research Reviews. And we thank Dr. Stitch for giving his time today.
It's a great honor to be asked to join this group, and I think that the Lyme Disease Association is doing some important work, and I would like to thank Pat for spearheading. Welcome our next speaker, Dr. Kenneth Liegner, MD. Dr. Liegner is a board-certified internist with additional training in pathology and critical care medicine. Practicing in Poly, New York, he has been actively involved in diagnosis and treatment of Lyme disease and related disorders since 1988. So he's been at this for a while. Thank you.
Thank you, Dr. Stitch. And I'd like to thank Pat Smith of the Lyme Disease Foundation, Dr. Fallon, Betty Maloney, for inviting me here. And it's a pleasure to be in this beautiful state and beautiful cities of Minneapolis, St. Paul, which I've never been before. I'd like to just start out by saying that first of all, that I'm a clinician, first and foremost. Lyme disease is a clinical diagnosis. So that means we need to take a very careful and thorough history and physical examination. It's very important to elicit the geographic history and try to discern what the degree of epidemiologic risk is involved. One needs to specifically ask about vocations, avocations, pet ownership, whether or not there are known tick attachments. Of course, absence of a tick attachment certainly doesn't rule out the illness. Same with any eruptions possibly consistent with erythema migrans. And it's interesting that a lot of patients who come to us never have been asked these very basic, simple questions. And then, of course, the different manifestations of illness, which can be myriad. one needs to consider carefully differential diagnosis, and then intelligent use of the laboratory, and also the understanding that these tests that we do have available have to be considered adjunctive, that sometimes they are conclusively diagnostic, but not always so, and you cannot completely rely on the tests. Then as a clinician, sometimes there is a role for an empiric trial of treatment, even in the face of uncertainty, and that there's need for very careful follow-up, careful study of the patient over time, both in response to application of treatment, but also during periods of observation off of treatment. As far as some of the tools that are available, I'll try to go through them very quickly. There's the immunofluorescent assay, which depends on a subjective call by someone looking through a microscope. So-called improvement is the enzyme-linked immunosorbent assay, which is more objective and uses spectrophotometry to quantitate intensity of color of a color reaction. There's the Lyme Western blot, both IgG and IgM. The Lyme C6 peptide ELISA, which if positive is mostly regarded as quite specific, but unfortunately it's not always that sensitive either. There's Lyme PCR, where you're actually trying to pick up the genetic material of the Lyme organism. Yes, it is a very sensitive method, but the density of organisms within bodily fluids is so low that even with a very sensitive method like PCR, it's very hit and miss. There's histologic identification by silver stain, either Dieterle or Warthin-Starry stain. The problem with that is doing these stains is a fine art, and trying to find pathologists who have the skills not only to do the staining, but to carefully search the tissues, which is a very laborious process, is hard to find. Paul DeRay, one of the physicians who was expert in that, unfortunately passed away within the last year. And Alan McDonald is still active, but is not clinically active. He's more in a research setting. There's immunohistochemistry. Klaus Eisenli, a dermatologist in Austria, has a method. There is antigen capture in spinal fluid that was developed by Pat Coyle and Steve Schutzer. Unfortunately, this is no longer clinically available. There was the Rocky Mountain laboratory developed antigen capture assay in urine, which I'm going to talk about in a little bit, and that also, unfortunately, is not clinically available. There is antigen capture in urine, one of which is IGNX's Lyme dot blot. More recently, a company called Ceres Nanoscience has developed a carbon tube method, which I think is sort of a more refined method of the urine antigen capture. There is Borrelia culture in BSK2, unfortunately hasn't been very sensitive, and more recently Dr. Eva Shapi has published on her method, which is being utilized by Advanced Laboratory Services, which according to her publication has quite a high yield, has not yet been replicated by other independent investigators. However, I know Dr. Shapi to be a very fine scientist and a person of integrity, so I am guardedly hopeful that this method will be substantiated. Some people are using lymphocyte transformation assays that was available through Stony Brook a while ago, sort of dropped out, and I understand there's some labs that are now offering that. It remains to be seen what role proteomic profiling will have, and I understand some labs are using cytokine profiling, but I would venture to say that's going to be rather nonspecific. I borrowed this slide from Betty Maloney. Thank you, Betty. Or the top part of the slide, in which the CDC does say that the surveillance case definition was developed for national reporting purposes and is not intended for clinical diagnosis. Nonetheless, so that is very important, that this epidemiologic surveillance case definition, which certainly defines a case as a case, but you cannot use it clinically. Unfortunately, the Infectious Diseases Society of America has been behaving as though that's the way you should diagnose Lyme. Also, the CDC still is promoting the two-tiered system of testing, and that is being held out as almost infallible, particularly in late disease, and I'll talk about that a little bit later. The seronegative subset is acknowledged to exist, but it's held to be vanishingly rare, usually early in the course of illness or with early subcurative antibiotic treatment. Also, the CDC has been rather dogmatically asserting that IgM reactivity on a Lyme Western blot beyond 1 to 2 months of illness should be ignored. And in my opinion, that is completely arbitrary and without any scientific basis. And there's a citation by Racine, not about Lyme, but that points out that IgM reactivity can be an important indication of chronic persistent infection, particularly with intracellular infections. And of course, CDC and IDSA have maintained that chronic Lyme disease does not exist. I want to mention some of the influences on my thinking. One is Stokes' classic Modern Clinical Syphilology. This is the last edition that was published in 1945, but it is just a treasure trove of information. He has a section on clinical approach to diagnosis of syphilis, and in reading through it, I was very impressed how similar that approach is to my approach, and I think that an approach that is still necessary dealing with the modern day spirochetal infection of Lyme disease. Also, Oscar Felsenfeld's monograph on Borrelia. This is way before Lyme disease was a twinkle in anybody's eye, and it talks about more relapsing fever borreliosis, but it's also highly relevant. Also, J. Lawton Smith's amazing monograph, Spirochetes in Late Seronegative Syphilis, penicillin notwithstanding, is a marked influence in my thinking. And then the landmark case of Vera Priak-Mursic and colleagues, the first documentation of persistence of Borrelia burgdorferi despite application of intravenous antibiotics. This is in the European literature, but a very, very important landmark case. The monograph from the New York Academy of Sciences, Lyme disease and related disorders, remains an excellent resource. And Holly Murray's book, The Widening Circle, also very, very well worth reading. I've also been very blessed to have wonderful collaborators during the 25 years or so that I've been involved in this field. Dr. Brian Fallon, this is in our salad days, Brian, back in, this is from the 1999 BARD conference. Also David Dorward from the Rocky Mountain Lab. And Claude Garan with his wife Sally, he had invited me out to the Rocky Mountain Lab back about 15, 20 years ago. And Paul DeRay, who was a wonderful collaborator, again, unfortunately passed away in the last year or so, and Alan McDonald. Dorward and Garan did very basic scientific work on the Lyme organism. This was published in Scanning Microscopy, in which they really studied the basic biologic properties of Borrelia burgdorferi. And what they showed was that part of its natural biology was to elaborate these membranous blebs in large numbers. And also, I didn't show the picture, but each of these blebs, if you lyse them, it liberates genomic DNA. So we don't fully understand the purpose of these teleologically, but I imagine there's some adaptational purpose for this. They took advantage of this to develop an assay, which was published in the Journal of Clinical Microbiology, in which they were able to characterize these blebs, develop an immunogold stain that adhered to these blebs, and then using electron microscopy, they were able to develop a test that could detect these in different animals and different fluids. Around 1989, 1990, through Derland Fish, who was the director of medical entomology at New York Medical College, it turned out his office was about a quarter mile away from my office. He knew that I was seeing patients who either had Lyme or who might have Lyme, and the CDC was interested in studying them. So he introduced me to people from the CDC. They invited me to send fluids from the patients I was studying who either did have Lyme or might have Lyme. So we sent large numbers of frozen sera, urine, and spinal fluid to them. And unbeknownst to me, at the time, they in turn sent some of these fluids on to Dorward and Garan at the Rocky Mountain Lab. So I'm one of the few clinicians who had the opportunity to have fluids from my patients tested using this Rocky Mountain Lab antigen capture assay. And this is a slide that was compiled by Claude Garan, which shows the results of some of the testing that they did. And they compared the RML, which is this electron microscopy using their immunogold assay, versus 3 different Lyme ELISAs. ELISA TQ stands for Tom Kwan, who's a researcher at the CDC in Fort Collins. The other is a sonicated ELISA, and the third is a flagella ELISA. So the notable thing about this, I think, is if you look at this column, it shows that out of 51 samples, 37 out of the 51 tested positive on this electron microscopic immunogol labeling when all of the other screening ELISAs were negative. So, you know, you have to take this in the proper context. This is an experimental method. But to me, this is a clue, you know, a window that this is a lot more complicated than people assumed. We did report this as a abstract in 1992 at the 5th International Congress on Lyme Borreliosis. And one thing I want to say is that the patients who tested positive were incredibly diverse presentations. I mean, way beyond, you know, the typical Lyme rash. One of them was a young woman, a beautiful young woman from Poquag, which is actually very close to Pauling, who did have a history of a rash entirely consistent with erythema migrans, tested negative on standard tests, and went on to develop fatal pulmonary hypertension. That case has never been really reported in the literature. Unfortunately, she was at Mount Sinai where they were treating her with experimental methods to try to treat her pulmonary hypertension, and she passed away, and most regrettably, the physician responsible for her case did not request an autopsy, which is really unfortunate. The conclusion on this little abstract was, study results using this direct antigen detection method suggest seronegative Lyme borreliosis is not rare and lends support to the hypothesis that Borrelia burgdorferi can persist in the human host despite intensive antibiotic treatment. I'm going to briefly talk about a couple of cases. One was a social Woika from the Bronx. She went up to Bear Mountain, which is a very favorite spot for people to travel in the lower Hudson Valley. It's a beautiful area, but it's also highly tick-infested. And she had a little lesion on her finger, and then about 3 weeks later developed a large eruption on the right anterior thigh that was a classic bullseye rash. She went to her local physician, who treated her with 10 days of tetracycline, and indeed the rash improved and some of the various symptoms that she had improved. But she came to consult me a little bit later, and I decided, she did have a few symptoms, and I decided to treat her somewhat arbitrarily for 3 months with minocycline, and she definitely improved. The rash lightened, most of her symptoms went away. But then a month or two later, she began to have a recurrence of symptoms, and a couple of months after that, the rash on the right thigh became more intense, and she developed a new eruption on the left thigh that was also looked like a ring-like lesion. So I did a skin biopsy, sent it for hematoxylin and eosin study, and the upper right-hand corner shows a dense infiltrate of lymphocytes cuffing small vessels. And again, I was very fortunate to be able to collaborate at that time with Alan McDonald, who took some of the tissue and did silver staining and visualized what he felt was a classic Borrelia in the dermis. She also tested positive by PCR. She had some important bands on Western blot, IgG and IgM, including 31 kilodalton band. But importantly, she was seronegative for Lyme disease by ELISA throughout. When we had this data, I went back and treated her with 10 months of minocycline. She recovered fully. She did follow up with me for a period of time and seemed to remain clinically well. So again, shows this is an obvious case, you know, where she was in an area where she had risk of tick exposure. She didn't actually see a tick, developed a classic rash, but the screening ELISA, if that was all you would have gone by, would have completely failed in diagnosing this patient. Another important case is the case of Vicki Logan. She's a pretty famous case. She was a pediatric intensive care nurse who developed gait disturbance and was documented over several years to have a lymphocytic pleocytosis. She went all over the place to the best physicians and the best hospitals. No one was able to make a diagnosis. She finally came to me around 1989. I studied her very carefully for a year using all of the methods that I had available, and I also was unable to make a diagnosis. However, I knew she had grown up in Golden's Bridge, which is in a very beautiful rustic setting in Westchester County, very tick-infested. We studied her very carefully. We're not able to make any other etiologic diagnosis, and because of that, I decided to treat her purely empirically, as though she might have Lyme, even though I didn't know whether she had it. I admitted her to the hospital. We did a spinal tap. We treated her with 21 days of intravenous cefotaxime. We repeated the spinal tap. There really were no changes, and also, unfortunately, she really didn't improve. Just for good measure, I treated her with 4 months of minocycline. Really didn't make much of a difference, and at that point, I backed off. I figured I'd given her the benefit of the doubt. About a year later, she contacted me. Again, she was still not doing well. She pleaded with me to do another spinal tap. At that time, through Derlin Fish, I had begun to work with people from CDC. They provided me with BSK2 culture media, and when I tapped her in December of 1991, I put a couple of cc's of spinal fluid into BSK2, shipped it off to CDC, and a couple of weeks later, I got an excited call from David Dennis at CDC Fort Collins, letting me know that spirochetes were growing in her spinal fluid. Those later proved to be burgdorferi by PCR. So she made the front page of the Science Times in the New York Times in 1993. That's me at Vicky's bedside at Northern Westchester Hospital. And this is the actual report that I received from CDC of her culture of her spinal fluid, showing that the identity of the isolate was confirmed by PCR. That's by Roy Campbell. We reported her case at the 5th International Conference on Lyme Borreliosis in 1992 in Arlington, Virginia. And you can see the collaborators were people right from CDC. And the conclusion was, culture of this CSF specimen in BSK2 yielded a strain of B. burgdorferi. Culture confirmed treatment failures have been previously reported for 3 Lyme neuroborreliosis cases in Europe. The present case apparently is the first of this type to be reported from the United States. This prompted a guest commentary in the Journal of Clinical Microbiology, and also an article with 3 other cases in the Journal of Spirochetal and Tick-Borne Diseases. Her course went on over many years. She ended up going to Mayo Clinic. It's a long story. She came back to us and in very severe shape, had developed pleuropericardial effusion, and we did a pleuropericardial window, both to avoid her from getting pericardial tamponade. And at that time, I was working with Paul Duray. He did a touch prep of the pericardium, and you can see a beautiful borrelial spirochete. And this is after already that she was subsequently treated with 13 weeks of intravenous cefotaxime in a pulse regimen once I knew that she had Lyme, and her pleocytosis that she had had for years completely resolved, and she did clinically improve. But once we stopped treating, she got ill once again. We also had the opportunity, years later, I had the opportunity to send some of her spinal fluid to the research lab of Dr. Raymond Datweiler at Stony Brook, which is using the methods that had been developed by Pat Coyle and Steve Schutzer of antigen capture in spinal fluid. I had the opportunity to send something like 140 specimens of frozen spinal fluid on my patients for this research assay. And what this is trying to show you is that using standard methods of ELISA and Western blot, only 2% of specimens tested positive on standard antibody assays in spinal fluid. However, using the methods that Schutzer and Coyle developed, which include OSP-A and OSP-C antigen capture and Borrelia-specific immune complexes in spinal fluid, 61% of the specimens tested positive. So again, to me, this was a window indicating that the tests that are clinically commercially available are quite inadequate. This was one of the patients whose spinal fluid I sent for that testing happened to be Vicky Logan's. Oops, let me go back on this. And just to point out that her spinal fluid for OSP-C antigen capture tested more than 7 times greater than the positive cutoff in spinal fluid. And also she tested positive for both IgM and IgG specific complexes. Okay, I'm going to have to really rush through. Her case is very complex. She unfortunately ultimately did come to autopsy, and the final diagnosis was chronic Lyme disease with chronic meningoencephalomyelitis. And this shows a blood vessel from her brain showing a dense infiltrate of lymphocytes and plasma cells. Plasma cells notoriously aggregate where there are spirochetes. And using the methods of Klaus Eisendley in the same area, there was uptake using his immunohistochemistry stains. I'm going to have to rush through the rest of the cases, because I probably spent too much time already. But one of those was a Catskill outdoorsman, Martin Eisenhart. He lived in Cairo in the Catskills, not far from scenes just like this. He had had a history of an eruption on his thigh that looked like a classic Lyme rash. His wife brought him to his physician, who didn't recognize the significance of the rash. He went on to develop severe neurologic symptoms, including stroke-like syndrome. He went to many different centers for care, and all of his tests for Lyme, his screening tests were negative. His wife kept saying, could he have Lyme disease? And even though he had the rash, and she was told no, because his screening test was negative. When he came under my care, this is what his MRI looked like. He had been treated as though he had a vasculitis with immunosuppressive therapy. And you can see he had huge enlargement of his ventricles. He was treated actually by me, and he did improve modestly, but ultimately he succumbed to his illness. This is his brain at autopsy with massive hydrocephalus. And the slide on the bottom is a section through his cerebellum showing florid meningoencephalomyelitis. Paul DeRay, at that time he was at the NIH Center in Bethesda. He showed this around to the neuropathologists. Nobody had ever seen anything like this. I was also able to send his tissues to Dagmar Herlinska at the Borrelia Research Center in the Czech Republic. She used electron microscopy, and she detected what she felt were spirochetes in cross-section. She also did PCR on both brain and meninges and was able to detect signal for burgdorferi in his tissues. And he had been on pulse cefotaxime for a year before he succumbed. This is a heartfelt testimony from his wife, Mary Lou, at the New York State Assembly Committee on Health hearings in November of 2001. And that's a picture of Martin when he was well, before he became ill. This scenario was also played out in children. One was a 6-year-old who had a tick attachment, an engorged tick on her neck. The mother went to the pediatrician, begged for treatment. The pediatrician refused. And then over the ensuing months, the child became very ill. Unfortunately, it was not recognized that this was Lyme, and the following fall, the child developed status epilepticus, requiring pentobarbital coma to control the seizures. The child ultimately came under the care of Charles Ray Jones, who referred her to me for spinal tap. At the time I did a spinal tap, the ELISA was negative, but Western blot at Stony Brook showed 4 out of 5 CDC-specific IgG bands. And Charles Ray Jones undertook to treat the child, and the child actually was improving, but regrettably, due to insurance factors, the treatment had to be stopped, and within a month, the child developed again intractable status epilepticus and succumbed. The child did have an autopsy. I am not privy to the results of the autopsy. Then there's the case of Jennifer Lilly, and I have her permission. Of course, all these patients whose names I'm mentioning, I have the permission of either the patient or the next of kin. She was camping in western New Jersey, had a known tick bite, classic bullseye rash, became quite ill, and went to something like 17 physicians. She was told by all of them she couldn't possibly have Lyme disease because her screening test for Lyme disease was negative. 3 years later, she eventually came to me. I diagnosed Lyme, of course, just on the clinical history, regardless of what the test showed, and started to treat her. And it turned out this was her ELISA and Western blot from Stony Brook when she came to me, and notably, guess what? The ELISA is negative, but the IgG and the IgM Western blots were fully diagnostic. I got a letter from the Frederick, Maryland Department of Health to report the case. And rather than just reporting it, I also sent a letter explaining her case and the need for improved testing, and also arguing that this two-tiered system of ELISA followed by Western blot is leading people astray. I also made a point of sending a copy to Thomas Frieden, director of CDC, in the hopes that here is a very specific case, black and white, hoping that it would affect CDC's position on two-tiered system of testing, and so far it hasn't, unfortunately. So, conclusion. Currently available testing methods for Lyme disease have significant limitations. Until such time as highly sensitive, highly specific, cost-effective, qualitative and quantitative direct detection methods that are universally agreed to for Lyme disease become widely, clinically, commercially available, diagnosis will remain necessarily clinical in the care of this illness. Expertise evaluating persons for suspected Lyme disease and other tick-borne illnesses is hard-earned and requires individual patient assessment the old-fashioned way, the way we were taught as medical students, how to spend time with the patient and ask the questions, and it's kind of a call and response, almost like improvising jazz. You have to ask directed questions based on what the patient is telling you, and you have to also ask the right questions. And this disease can be really quite baffling. And there are so many diverse presentations which can occur. It is time-consuming to evaluate these patients. Physicians must inform themselves of the now voluminous and expanding worldwide scientific literature in the field. Diagnosis requires application of inferential reasoning as patients are studied over time and in response both to treatment interventions as well as observation during periods off treatment. Serial study and reassessment over time using those diagnostic tools which are currently available as appropriate can help raise confidence level as to diagnosis. We should, however, continue to look to the horizon for the arrival of improved and validated diagnostic tools for Lyme disease and related borreliosis. There are references that I've put together here, but I also want to thank Betty Maloney, who was kind enough to let me use some of her references going through the worldwide peer-reviewed literature demonstrating the great limitations of the available test methods. So, Betty, thank you very much, and those are listed here.
We have a little less than 1 minute left, so one quick question if anybody has one. There's a microphone right up there, sir.
It's not the antibiotics that carry the day. It requires an efficient immune response to heal the patient. Were there any signs in these patients, Vicki Logan and the others, of immune deficiency, or do you suspect that there's some as yet undefined immune deficiency that accounts for why these people get so well despite the antibiotic treatment?
The immune response, of course, is extremely important. The patient immunogenetics is very important. We've seen a small subset of our patients, and I don't know how often this would occur in a general medical population, who have definitely decreased IgM, and it's notable. And we do know that Lyme and these other tick-borne diseases themselves can affect the immune response in ways that are still not well understood, but I think there's a fairly wide acceptance that there is immune impairment of some degree commonly in the patients with these tick-borne illnesses.
Thank you very much.
Thank you very much for your attention.
Any questions? You're welcome to walk up to the microphones and ask away.
I have kind of a series of questions relating to the diagnosis, because every test and study we seem to be presented with comes up with the positives and negatives, but I've never found a reliable test or what is the gold standard to diagnose Lyme disease. So if you're comparing the ELISA or the Western blot, what are we comparing it to? How are we substantiating that this is a case or not a case? And is there any reliable source of positive or of false positive, false negatives for each of these tests?
If I had to use a single test of what's available now, it would be Western blotting, IgG, and IgM. But also, you have to select your lab because many of the commercial labs set their cutoffs high, so you don't get so-called false positives, but you end up with a lot more false negatives. So I usually send out to at least 2 different good labs and always ask them to report all of the bands on the blot, not just the CDC-specific band. So one of the labs I use is SUNY Stony Brook, the other is IGENIX, and between the 2 of them, you're often able to get some clues. I disagree with the notion that's being promoted by CDC that IgM reactivity beyond a month or 2 is false. And actually, many of the people that we deal with very late in the illness show an expanded pattern of IgM bands, making me think that there's a ongoing antigen presentation, and that's why the IgM is positive. And when you see that expanded pattern of bands, it means your immune system, the patient's immune system, has had a chance to recognize many different proteins on the organism. So given the current state of the art, if I had to choose one test, it would be the Western blot from good laboratories. Again, if the advanced lab culture proves itself, that will become a new gold standard. That work is still in progress. But obviously, culture, reliable isolation, becomes a gold standard.
Is the rate on the Western blot established by biopsy culture? How do we know?
No, I mean, we don't have a gold standard, so you have to use that. Again, given the current state of testing, you have to integrate that into all of the clinical data and following the patient over time, because often one, as a clinician and also as a patient, there's a period of limbo, which is very, very uncomfortable for everybody. And only with the passage of time and study of the patient and trying to accumulate more data, you can get a higher level of confidence. But there is that limbo, and I think patients can deal with almost anything once they know. But it's that state of uncertainty that is so agonizing for everybody.
Ken, if I could add something to the Western blot analysis, and I'm actually going to be talking about this tomorrow, and that's the inclusion, and you allude to this, but the inclusion of the highly specific bands 31 and 34, which are not on the standard kits for LabCorp and Quest, and that will expand the sensitivity.